So on one of the items, I know that the department is not ready to talk about the specific numbers in regards to the mover study. That is an item that we'll get back to, and for 2009, I know is funded, and I know Mr. Doyle's all over it. So thank you so much for looking into that. But I know that we won't have that today. Would like to be able to talk about the issue of vacancies and the process that worked and that didn't. And what you're saying, Mr. Kotke, is that by paying down the position within the facility, within the home, it provided incentive for the state to be able to fill that specific slot, if you will. And I don't mean to be flip with the term. Can you go into that? Because what you're saying is if it, I know I'm paraphrasing here, sure. If it was not paid prior, many times if the work was done the way I understood it, if the work was done to be able to have the home ready, at times that sat vacant. Can you just go into a little more detail on that?
Sure. From a financial perspective, the real challenge for a provider is that we have, when we're developing for DC closure, we're developing a home for people transitioning out of a developmental center. We have a startup phase where we're given grant money to hire staff, furnish the home, prepare for people to move in. And typically, then you have a phase where you go into what's called purchase of service dollars, and that's a per person per month amount that you're paid to provide services. And so if, in our case at Elwyn, about 78 to 80% of our budget is in staffing. So we're preparing the home. We need to bring all the staff on. From a practical perspective, you've got to give the staff hours in order to retain them. And so if you then move out of startup, you can no longer access that money, and you're being funded on a per person per month basis and not funded for vacancies. You're carrying a full staff for initially, say it's a 5-bedroom home, 1/5 of the revenue needed to support the home. Then when the second person moves in, you're running a home full capacity staffing on 2/5. And so with the Agnes closure, there were transitional dollars, and that meant in between that startup phase, after the first person moved in, you're out of startup, you no longer access that money, but there are transitional dollars that pay for a full complement of staff, or as if the home was full, for a period of time during which additional people are moving in. So the first person moves in, you get transitional dollars, and then the balance of the people move into the home, and you move into the typical per person per month funding revenue. And because regional centers are stewards of those dollars, in that design, there's more pressure on the regional center and DDS side of the house to make sure that all due diligence is provided to move people in, because they can't justify, spending those dollars on prolonged vacancies. But what that also does, in addition to keeping the provider whole, is it allows for, if there are clinical reasons why somebody shouldn't move in, as opposed to bureaucratic reasons why somebody can't move into the home, then the provider can stay whole while those clinical reasons are being worked out. So if a person medically isn't stable, they get sick, they are not comfortable with moving forward, they come to the home for a visit and it's not a perfect match for them, then you can take additional time to help stabilize their health, help them become more comfortable with the move, but the provider isn't being held in jeopardy because they're down the rate for that vacancy.
That is really helpful in being able to go in the explanation. And I was just, as you're going through this, was also just taking a look at on some of the written detail on that. And again, though, it incentivizes, candidly, it incentivizes the state to move since the dollars have moved prior to the resident moving in.
Yeah, it's an incentive for the state. And also, as I said earlier, ensure
the services are there, quite frankly.
Services are there. And in the process of transitioning people out of developmental centers, I mean, it's a very bureaucratic process. It's very complicated. There are a lot of entities involved. There are the teams at the developmental center, the regional resource development projects, the regional center, the person, their family. And there are a lot of wrenches that can get thrown into that process to cause delays. But if the funding is there, the regional center and the department have more leverage with the teams at the developmental center to move things along. If the funding isn't there, then it's really the provider that is under pressure to move things along, because, I mean, they want to fill the home. They want to do things that are clinically appropriate and good for the people moving in, but they also can't afford to sit with a lot of vacancies for an extended period because they're bleeding money.
Absolutely. No, thank you so much. That was really helpful in wanting to make sure that I had accurate, so thank you.
Can I just follow up?
Please.
So the Ag News experience, how long was the transitional period that people received funding?
It did vary a little bit from home to home, but I would say in our experience at Elwyn, people from the time the first person moved into a home, it was no more than a month or a month and a half until the last person moved in.
Oh, okay.
It was just a very well-coordinated, well-planned transition plan by home and by person, you know,
Right.
of course, but also by home, so that there were concentrated resources for each home and a plan for each home before the first person moved in, and so that we had that timeline already set, and we knew when the last person was projected to move in.
And was the experience not similar with the Lanterman closure?
No, I don't feel that it was. And I know that for myself, it took 2 years for my son to be moved into the community, and it was making sure that I found all doctors and all services prior to moving, because I found out from other families that came and told the PCC that it was hard to get services for specialized services after they moved. And so I wanted to make sure all my son's services were going to be in place beforehand.
Or before you move? Okay.
Yes.
Thank you.
And it's difficult for parents who are older and are intimidated to try and make sure those things
Do it
happen
yourself,
beforehand.
right. Thank you.
Thank you so much. Anything else, Senator Liu? Any items from Senator Mitchell? No. Okay. Absolutely. Ladies and gentlemen, thank you so much for your time, and we are grateful that you would hang with us for so long today and for your wonderful testimony and very informative. Great job. Thank you very much.
Great job.
Hey. All right. We're now going to be bringing forward our final panel this evening, and then we'll be opening it up for public comment. This final panel is going to be maintaining a safety net. What we're asking is what should be on the state's ongoing role in providing unique services, addressing unmet needs, and ensuring the well-being of those with challenging medical and behavioral needs are met. We're going to split this up here in 2 ways. Our first panel is going to be Eileen Rishi. She's the Director of Association of Regional Center Agencies. We're then going to hear from Kathleen Miller. She's President of the Parent Hospital Association from the Sonoma Developmental Center. And then we're going to have Ray Sarajoli. Did I get that? Hopefully. Fairview Friends and Friends Incorporated. And then Willie West, who is a client, is going to be talking about his personal experience. So what we understand is Ray needs to get on to Southwest here shortly. So what we're going to have, if it works for folks, is we're going to have Ray go first. Again, he is from Fairview Families and Friends. He's going to talk about the need to enhance community services based on his own experience at Fairview Developmental Center. And then we're going to kick it to Eileen Rishi, who's the Director of Association of Regional Center Agencies. Ray, we're really grateful that you are here, and the floor is yours, sir. You have 5 minutes.
Thank you for including me in such a distinguished panel, and good afternoon. My name is Ray Saragioli, and I'm the president of Fairview Family and Friends Incorporated. Fairview Family and Friends is a California not-for-profit. We were organized in the year 1964. Our membership consists of parents, conservators, friends, and relatives of the clients at Fairview Developmental Center. We have regular meetings where we invite speakers. As an example, in our last meeting, we had 3 regional directors and a whole panel of speakers from DDS. FFF, Family, Friends, and Fairview, we provide a newsletter that goes out to about 800 people, and we also have a website. So I wanted everybody to know who Fairview Family and Friends is. I am married and have 5 children, and my oldest child is John. John this year will be 61 years of age. He's developmentally disabled, and he has been a resident of the Fairview Developmental Center since October of 1965. So he's been there about 50-plus years. It has been his home. The staff and residents are his family. Very briefly, when it was announced that Fairview was going to close, I received telephone calls, messages, Sunday mornings, Sunday nights from concerned parents, conservators, and I'll tell you, there was anxiety, there was fear, you name it, and I was told frustration. And it ranged from all the way to we shall fight closure to an acceptance, although reluctant. On February 6th, a couple of weeks ago, the Department of Developmental Services held a meeting at Fairview that lasted from about 10 in the morning to 5 at night, where all speakers were invited, just not members of Fairview or their parents. All kinds of views ran as to what should be done with Fairview land, what should not be done with it, it should not be sold. For those of you that don't know and you have not seen it, Fairview is about 110 acres of flat, level land in the middle of Costa Mesa.
Ray, you have 2 minutes, sir.
Thank you. To get on quickly then, and I'll make it as quick as I can. One of the main things I want to get to, and a lot of what I was going to say has already been said by other people as to the concerns and why. I want to talk just briefly about why we are here, and we are here because of the individuals that are developmentally disabled. That is why we are here. And just to take a quick briefing, the needs of those individuals is done by what we call an individual program that the staffs at each residential center do. It's written, very comprehensive. In addition to that now, that there has to be an individual assessment required under the law by each regional center. Our family has gone through both. The last individual assessment of our son, and to tell you how they're done, some of the regional centers are using their own employees. Our regional center used 3 independent medical contractors to do it. We met with them, my wife and I and family met with them, they met with staff, and the report that came out was over 60 pages. Very comprehensive, very fair, and told what his needs are. If you can imagine someone doing a report on you, where they know what kind of food you like, what clothes you like, what your complete likes and dislikes, what your IQ is, medical problems, etc. It was a very fair report. And I think under the law,
Ray, you have 30 seconds, I
the
apologize.
state of California owes an obligation to these individuals and the needs that are listed in those reports. Not only do we owe a legal obligation, I think we owe a moral obligation to them. And that's why we're here. We're here because of the individuals and to make sure that their needs are met once they're transferred to the community. We have to follow those programs and the needs that are set forth in order to be successful. May I have just 2 more seconds? One of the big concerns of the parents, 2 things. Number 1, while you're talking of closing Fairview, there's still going to be placements for Fairview. We are now down to 248 residents. The statistics are that you're dealing with an older population. Approximately 65% of the population at Fairview is over the age of 50. If I go down to 40 and above, it's almost 80% of the population. So not only do you have aging clients there, but you also have aging parents. And with the age come additional medical problems and so forth. Well, one of the problems is, while you're having...
I apologize.
Okay.
Hey, there we go.
I'm sorry.
No, you're doing good. I don't mean to be pushy with you. I just want to make sure we get to the rest of the panel.
All right.
I want to make sure you catch your flight, too. Hey, there we
true.
go.
Again, thank you, and someday maybe I'll be able to tell you the rest of the story.
Hey, there we go.
Thank you very, very much for including me.
Ray, I just want to see, before you leave, and we'll hold on questions for everyone else, but I want to see if anyone has any questions for you. Is that okay?
Fine.
All right, thank you so much.
Absolutely.
Senators, Ray, I have a quick question for you. Talk about...
I'll be able to answer, but go
Hey,
ahead.
there we go. I just would like, there's been a lot of discussion about communication and making sure that the state is a good communicator, obviously with residents and your son and with yourself, and employees as well. Can you talk about that communication thus far?
Let me start from the FFF point. We try and pass on as much information as we possibly can as to what is happening, with handouts, with speakers, in our newsletter, and on our website. So the communication there is excellent. In addition to that, whenever I call DDS or anyone else, I get an answer that we try and pass on. So I think the communication aspects of it are excellent, and I hope it continues, because we really need people to be informed as to what is happening.
Absolutely. Please, Senator.
Very quickly, you made a distinction when you talked about who did your son's plan.
Right.
And you made the distinction that sometimes it's regional center employees, but in your case, it was independent contractors.
Right.
Was there a reason you emphasized that distinction? Do you think that that's the preferred process? I wasn't sure.
I personally felt that the independent contractors, because they spent, I'll tell you, if you can imagine my son being there 50 years, they had to review 50 years of medical records, psychological reports, which they did. They met with staff. They observed him. So they spent hours and hours of time, rather than the regional center, say, picking out a social worker, maybe site tech, and someone else, you do the report. So I thought it was a very unbiased and a very fair report. One last thing, since you asked me a question. We just went through a follow-up on this year's assessment. One thing I wanted to mention, very quickly if I may, and I got to catch a plane. I really do. And we have other people that have come down with me. Today we heard that the egress and so forth on some of these family homes, and that there's a warning system supposed to go off. And you heard one of the speakers use the word eloper. My son is an eloper. Not that he runs away, he just kind of wanders away. And if he's in a family home and he gets out of that home and they don't catch him, he doesn't speak, he can't tell a police officer's name, where he is, where he lives, so he's going to be at the mercy. The Glendale Police Department in Glendale, California has come up with a program for a GPS bracelet, not just for the disabled, for people with Alzheimer's and dementia. And they found it works well, and the initial cost is only about $300, the initial $100 a year thereafter. And I think of how cheap that is, thinking of law enforcement going out, trying to find somebody, and maybe the lawsuits that are going to ensue afterwards.
Absolutely.
May I go now?
Hey, there we go.
Thank you.
Hey, Ray, thank you so much. You did a great job. We're grateful. And Ray, I owe you an apology. I butchered your last name coming up here.
You pronounced it right.
Oh, hey.
You pronounced it right.
All right, I thought I butchered it, so I apologize.
But
Hey,
if I give you the Italian pronunciation, I'll follow you up.
say it for us real quick.
Chadajol.
Yeah, you're right. All right, hey, there we go. That's what I'm saying. Ray, safe travels back, sir. Thank you so much for taking the time. All right, you did a great job today, and we're really grateful that you would take the time to come all the way up. So thank you very much. Thank you so much. No, thank you. All right, ladies and gentlemen, we'd now like to move on to Eileen Rishi. She's the director of the Association of Regional Center Agencies. She's going to talk about the need to stabilize the community system. It has been such a challenge. It is great to see you again, and thank you for all of your hard work. We're excited that you're here.
Thank you. Eileen Ritchie, I'm the director of the Association of Regional Center Agencies. I do have written testimony, so I'm going to, in the interest of time, I'm just going to summarize that testimony. ARCA represents the 21 regional centers that coordinate services and advocate for people with developmental disabilities. 2 questions. First question was, what are the most important services and supports that must be maintained or established during and post-closure? The IPP outlines the types of services and supports individuals will need in the community. The following are the most critical components to ensuring a smooth transition: regional center service coordination, adequate staffing, residential options, day and work services, reliable transportation, timely medical care, dental services, psychiatric services, and durable medical equipment. An area of concern has been with the median rates. I know that that is something that has been mentioned by other panel members, but certainly the median rates are a barrier to placement of individuals in the community, not only from the developmental centers, but also currently living in the community or at home with their parents. The health and safety waivers, which provide an opportunity to get around the median rates, is a very cumbersome process for both the Department of Developmental Services, regional centers, and service providers. Second question, what will happen as developmental centers are closed to residents who fail in the community? In 2012, California halted most developmental center placements and committed to reducing its use of other institutional settings as well. Since then, regional centers have partnered with the department and community service providers to develop service models to address challenging needs. These services include crisis services, community crisis homes, enhanced behavioral supports homes, delayed egress and secure perimeter homes, and forensic services. Nationwide, 14 states have closed all of their institutions for individuals with developmental disabilities. Yesterday, the Senate and Assembly Conference Committee met to vote on significant additional financial resources for the community-based developmental services system. If approved, it will improve the stability of the service system. This will also provide a clear path toward desperately needed funding reform for our service system. I'd like to thank both Senators McGuire and Mitchell for convening the hearing. Thank you.
Thank you so much, Mr. Ritchie. And what we're going to do is I'm going to have you hold, and we'll open it up for questions afterwards. Thank you. And if anyone does have written testimony, if you can just provide it to the sergeants, or if you have it now, we can take it now. But if any of you have now our current presenters or previous, we'd love to be able to have it in written form as well. It's now an honor to introduce Kathleen Miller. She's president of the Parent Hospital Association of the Sonoma Developmental Center. She's going to talk about our organization's commitment to retaining the services and improve community services in addition to the SDC. She's also going to share her concerns about the risks presented by the accelerated timing of the governor's proposed closure plan. Ms. Miller, thank you so much for hanging with us and your patience.
Thank you. And I'm actually talking about, challenges in the community. So thank you for the opportunity to speak. I want to start by saying that each regional center has its own unique challenges, but it seems like some challenges are common to all. We've heard about some of these already, including access to dental care. I want to be a little more specific. Regional centers sometimes get the services of a hygienist that can come out and do cursory cleanings for some individuals, but if the individual needs a cavity filled or root canal, then there's a problem. And sedation dental care, necessary for almost all DC movers, can be difficult to attain. Currently, the only access in most regional centers for anesthesia dental is in hospital settings. There are long wait lists. When a client finally does get in, and nobody's talked about this, teeth often end up being extracted. And we really need dental care in an outpatient clinic setting like we have in the developmental center, so clients can have access to meaningful care that actually saves their teeth. Medical care is a big, massive, complex issue, and I can't fully address it in the time I have here, but I can say this: many individuals with developmental disabilities are going to require more time than the HMO providers can give. Without this, critical issues are too often missed. The critical sharing of healthcare information is another challenge, and for clients who are nonverbal or who have behaviors and limited understanding of what's going on with their bodies. Sometimes information isn't available to those who are treating them, and that presents challenges and dangers. Medication management for our most medically fragile and dual diagnosis is beyond the scope of knowledge of many HMO providers. Challenging medical and behavior clients need primary care providers who know them and their issues. In order for physicians to successfully treat these difficult-to-serve people, they need to be able to spend time with them and their medical histories, and to be also made aware of current problems as they occur. If things are missed, medically fragile can end up in the hospital or dead, and the mentally ill end up in psychotic crisis that displaces them from their community residence. And when this happens, they begin the downward spiral to increasingly restrictive and expensive placements. I'm going to skip. I was going to talk about staff, but we've heard a lot about that, so I'm going to skip that, and I'm going to talk about something that hasn't been talked about. Simply put, not all developmental center there's a lack of reliable data, and that's a serious problem. And when PHA was able to get access finally to risk assessment data from Lanterman and that closure, it was discovered that the process of data collection was deeply flawed, and that much of the data was meaningless. So when you hear about their skills are improving, it's not based on valid data. Also, the remaining data was inconsistent, incomplete, and presented in a confusing way. Without appropriate data analysis, the understanding of the issues related to closure is anecdotal at best, and at worst is boldly inaccurate. Finally, simply put, not all developmental center clients are going to be able to be maintained in their community placement. In the Lanterman closure, it appears there were at least 10 individuals who failed in their first placement in a matter of a few months. We currently have SDC residents who didn't last 48 hours outside of SDC. Some former DC residents are initially successful, and then their mental illness or their behaviors escalate, and then things fall apart. My son, who lived in a community setting, was one such individual. he had to go back to the DCs. I want to share the story, however, of a young man who never lived in a DC. Mikey was an autistic young male who was raised at home. And he lived with his parents, and he was fine until sometime during puberty when his behavior escalated and he became violent. His father became afraid to leave him at home alone with the mother. The parents appealed to the regional center for help. No community facility was equipped to take him. It was agreed that he would live in the family home and the parents had to move out. The regional center brought in round-the-staff clock treatment, it's called the supported living model, to care for him. Sadly, the supported living staff wasn't really equipped to deal with someone like Mikey. Staff turnover was high, and when Mikey was supposed to have 2 on one staff, only 1 would show up. Finally, the provider quit, saying they could no longer provide services. The parents asked that he then be placed at SDC. They were refused. There was no other provider. They tried others. They failed. He was placed in a lockdown facility 13 hours away from family, the only support he ever knew. The facility was not inexpensive. It cost about the same as a DC would cost for his care. After 2 years, the family got a call that Mikey was dead. The circumstances of his death remain unclear. Mikey was 25 years old. SDC has a number of folks very like Mikey. His story could be my son's story. The DDS plan for these individuals has not been tested. It is restrictive, and I believe will prove unsafe for those who are confined in delayed egress secure perimeter facilities. The federal government doesn't want to pay for or have anything to do with these proposed facilities. As an alternative, the Sonoma Coalition is suggesting a small residential site where residents from all over Northern California can have placed, and they can have access to the outdoors, professional staff, day programs, and more. In other words, real treatment. Today, we have critical choices to make. This isn't an issue of money, really. It's an issue of will. Dental services in hospitals are expensive, and the expense assures that the dental clients are going to lose their teeth instead of getting real dental services that you and I would expect. Repeated visits to emergency rooms due to poor medical care does not save money or lives. A lack of mental health services where dual diagnosis clients end up in jail, psych wards, hotel rooms, emergency rooms, or secure facilities is not only expensive, but it's inappropriate and inhumane.
Maybe I just need you to wrap up in about 30
Okay, I'm done. I mean, the Sonoma Coalition is working to come up with real solutions, and we hope that all partners are going to continue to work for us and work with us, and we just find it very important because lives are at stake. Thank you.
Thank you so much. And Ms. Miller, if you don't mind sticking around, and we're going to be opening it up for questions here in just a bit. And thank you for your personal story as well.
Thank you.
Thank you. It's good to see you.
Thought you needed a story.
No, it's great. Thank you. We are now excited that Willie West is here. Mr. West is going to talk about his personal experience when he moved out of a developmental center and into the community. Mr. West, it's great to see you, and we're excited that you joined us today. How you doing?